So the next session is on the experiences of people living with dementia, their care partners in the community. And I'm really delighted that we will be looking at very different parts of the world. We're going to start with a presentation from India by my colleague from the Stride Project and the Nyman's Institute, Priya Thomas, Priya, and then we're going to go to the UK and also internationally with Clarissa Giebel, who's going to present on COVID-19 and dementia in the community from UK evidence to a systematic evidence review. We'll then go to Hong Kong, and great to see Cheng, also a colleague from the TIPCARD project and previously at LSE, looking at whether informal care compensates formal care as a consequence of COVID, and very interesting data. And then to Canterbury, where I am actually based, when I don't know if I see her, I don't see the camera on yet, with Stacey Rand from the PSW at the University of Kent, who present a cross-sectional study during COVID of social care-related quality of life of people with dementia and their cares in England. So thank you very much, all of you, for joining. We're going to start with Priya, see if you can share your screen. If not, we will help out. And I think that looks very good. If you just press on the box at the bottom with the kind of thing underneath next to the side. Yeah, almost there. A bit more to the bottom, Priya. It's very funny to see the mouse moving around. We can't see the screen at the moment, Priya.
Yeah. Can you hear me? Can you see
yes.
the slide? Yes.
Thank you.
Thank you. So thank you so much for having me here. Thank the organizers. And we are going to take a slight detour into India now, trying to see how dementia care has been impacted by COVID pandemic, and how I would like to present a small study, not a small study, a study that we have conducted in this context, our team in India. I would just start. Yeah. So I would like to begin with this context that in dementia, in the Indian scenario, dementia continues to be a major challenge, with the percentage of people being aged, the demographic transition that is happening in India, as in many other parts of the world, continues to be putting a lot of challenges in the healthcare system and in the society at large, as these graphs can tell us. And the projections on the number of people living with dementia in India are projected to increase in a quite astonishing rates. With by 2050, we are looking at as large as about 14 million people being affected with dementia. And COVID has been a major challenge, as in many other. I'm sure that there has not been a single person in this entire world who has not been affected with COVID in some way, one way or the other, influenced by COVID, which is a reason for all of us coming together also to discuss more and more about the impact of pandemic in care and impact of pandemic in people. So India has been very severely affected by COVID, and as these numbers can kind of tell, it continues to be a problem, though the major peaks have come down, and then we are on a kind of lease from the major COVID difficulties. Over a period of time, the vaccination also has kind of caught up with the numbers. It's too large a number to read. So I would just say that the total vaccination has kind of been able to reach out to a lot of people in the community. So in this context, and in the pre-existing context of long-term care for dementia in India happening very regularly at home and with very limited support from institutional or even informal caregivers who can come from outside and provide care. Very often, a patient or a person with dementia is cared for by one or more family members, and this kind of takes a toll on how families take decisions on care provision, and out-of-pocket expenses are quite high based on how much emotional and instrumental support and resources can be harnessed. So the decisions for care are often taken based on how much support can be harnessed at a given point of time, and how much of support and how much of resources can be distributed over different care needs or different needs that the family has. And the existing schemes and insurances and multiple, whatever available schemes often covers the cost of medicines, but not any other support services. So this has been a pre-existing condition in terms of dementia, long-term care in our country, with many of the persons and their families struggling to meet the care needs per se. And COVID has kind of impacted this pre-existing situation. And it was in this context that we conducted a 3-phase study to understand how our persons with dementia and their families have kind of managed through this COVID-19 pandemic. So this was a home-based caregiving, how much the COVID has influenced them. That has been the focus of this study. This data was collected when the country was coming out of a nationwide lockdown in the initial phases of the pandemic in the 2020 May to June time. So this the first phase and the nationwide lockdown that was coming down. So the lockdown has been a major challenge for the families who are providing care for our persons with dementia. And in this phase, we contacted 104 persons, and with a mean age of 65 years, with a duration of 3 years approximately. Many of our persons with dementia and families have been from middle income, with a multiple diagnosis being represented. And as is a prototype of caregiving in our country is also that the caregivers are primarily women in general. Usually caregiving is seen as a kind of extension of their direct caregiving role in our families. So in many instances, caregivers will be family members who are women, and that has been represented in this particular study also. We conducted telephonic interviews wherein neuropsychiatric inventory and CDR, depression, anxiety, stress scales, and a semi-structured questionnaire were administered over the telephone by reaching out to our persons with dementia and their carers. And the semi-structured schedule was basically to look at how much of qualitative information we could get. And so from this mixed method approach, we could find that many of our caregivers felt that the care, in spite of pandemic or no pandemic, the unchanging reality of caregiving and the challenges associated with this care continued to be a difficulty. But in spite of, at the same time, there has been a nearly 1/3 of them who have difficulties in accessing appointments with physicians, different care, because the home-based long-term care in dementia in our country, it requires support from multiple sources such as healthcare facilities, also social care facilities, wherever possible when families are trying to manage. So they have difficulties in accessing whatever support they had in place by that time. Many outdoor functional rehabilitation activities stopped during the lockdown, and that has been just as simple as going for a walk in the park they were not able to do. And that led to a lot of difficulties in participation of outdoor activities, leading to multiple changes as can be evidenced in this table that we are talking about. There are difficulties that people faced in terms of NPI. Certain changes happened in terms of their psychological problems. Also caregivers found that there was a lot of difficulties, but at the same time, many of them said that they are able to manage in the early phases of the study. over a period of time, after a kind of 6 months or so, we revisited the same group of people, and later, this was in the later periods of cluster of cases transmission phase in the October month. And among the people whom we were able to reach out, 66 participants completed the follow-up interviews. And in this, the main age of people, participants were 67%, and methods were very similar to the phase 1. But in this phase, we also found that the proportion of people with dementia increased, and that was a challenge for us to realize at that time. And fairly high percentage of people did not have anxiety at the early stages, which is in the first phase, manifested the symptoms in the follow-up. And caregiver distress was found to be significantly associated with the dementia severity and also NPI symptoms at this follow-up. Difficulties in accessing follow-up, and I think to a great extent we can take it as a natural progression of problems, in that people who had the lockdown in the early phases, they were kind of looking at how best they can manage, and they responded quite not so difficult, they were managing. But then as time went on, and then the lockdown continued, and the difficulties associated with the pandemic continued, and they had more and more difficulties in accessing the follow-up appointments with physicians and regular checkups and things like that. Fear of COVID infection remained, and the prevention measures were maintained and things like that. Further, after about a year or so, we revisited the same group of people in the June to October time period in the year 2021 this year, and this was compared to the established baseline from the first phase 1. So this in this phase, we reached out to the same group, and 68 participants were followed up in this phase. Again, clinical dementia rating scale, as well as brief interview regarding vaccination, we wanted to find out at this phase, because this was the time when nationwide drive for vaccination was also picking up, and large number of people have been vaccinated in the country. And so we wanted to know how our people responded to the possibility of vaccine, and whether they are able to take it or not. So we found that statistically a very significant difference were there in the dementia severity between phases 1 and 3. Again, whether the natural progression of the disease explains this or not is something that we need to still analyze and look at it. But the severity increased tremendously, and then 39.7% of the people were vaccinated, which is a less number as compared to what we would expect. 60% of the people were not vaccinated, and many of them gave the reasons that people are afraid, and worsening of the condition led, as in the disease progressed, and so the worsening of their condition itself acted as a factor for the caregivers to decide not to take vaccination. And uncertainty regarding the impact of vaccination on the person with dementia continued. The difficulty, many of them were not sure whether a person who is having a neurological problem, who is established as having a neurological problem, can safely take vaccination or not. So that kind of questions prevented many of the caregivers from opting for vaccination. Probably more important than these were the difficulties, just practical difficulties of going outside and getting vaccination done has been another reason that our people cited. So the difficulties of vaccination and difficulties that the people with dementia faced and their families faced continued. And this, to a great extent, the caregivers felt that there has not been a major change in terms of problems that they are facing in provision of care, but COVID made the situation very difficult in terms of accessibility and in terms of worsening of problems due to the enforced need for the people to stay at home. In this context, I just want to share one experience we had with one particular person with dementia whom we were working during the COVID time, who reached out to us. Mr. V is a 72-year-old retired bank manager who lives with his wife, son, daughter-in-law, and a 3-year-old granddaughter in urban Bangalore, which is a South Indian city where my hospital is based. This care arrangement is quite common in India, wherein the elderly people stay with wife, as an elderly couple stays with son, daughter-in-law, and children. This person was maintaining really well, but then there has been a decline in personal hygiene, inappropriate social behavior, and disinhibition, even pre-COVID time. In fact, from 2019 onwards, there has been problems. But COVID-19 pandemic and the lockdown meant that his social interactions were brought down quite significantly. It became next to nil. In that earlier, there has been an established friend cycle for this person. He was a retired bank manager who had his own circle of friends. So even when there was certain problems in functioning, he has been able to kind of go out and spend some time with his friends and things like that. But COVID meant that his social interactions and going to park and all these things became less, with the result that the enforced stay at home led to more and more problems being noticed in terms of inappropriate behavior. And the family reached out for help to the healthcare team when two incidents of inappropriate behavior with the primary caregiver, who is the daughter-in-law, had caused major distress in the family. Meaning to say that to the extent that the daughter-in-law's family had intervened and then she was taken back to their home and things like that, there were a lot of interpersonal issues that were happening. So that significantly created a lot of problems. So due to COVID, there could not be any other solution for them to kind of reach out. And because none of the hospitals at that time or care homes at that time wherein a respite could be sought, they were not able to, they were not admitting new inmates at that time. So they had to manage from home. And at this point, we tried to reach out, and a lot of interviews were conducted with different family members, targeting the identified difficult problems, and some amount of home adaptations and physical changes, as well as some interpersonal family interaction care arrangements kind of looked at. So we had to work with the family in spite of COVID, in spite of whatever lockdown and problems that were there that restricted their movements within the home itself, the adaptations and care arrangements that we could do, so that the effect of the behavioral changes and even the restrictions, how much it could be minimalized, it could be minimized, so that the family can go forward. Multiple sessions were conducted, and then over a period of time, we found that we could help the family to a great extent. The daughter-in-law could come back home, and we also made sure that to some extent, and with a lot of precautions and all, the social activities could to some extent start for the person. So with individualized care, person-centered care, this person has been, and the family could reach out to a little bit better quality of life. So to conclude, I would like to say that during the COVID pandemic, the persons demonstrated a lot of disease progression. Part of it is natural progression of the disease, but this was accelerated by the kind of enforced difficulties that they had. And these are likely to be correlated with the interruption of their care and functional and social activities. And these challenges were associated with increase in caregiver stress, which is always the family who faces the brunt of it. And efforts at this point need to be made to address the care needs of persons with dementia during the pandemic. So as I was discussing in the last case, it has to be extremely individualized and see whether a particular patient and their family can be helped during this process. So that is what we wanted to share from our side. Thank you so much for this opportunity. Thank you, Adelina, for this opportunity. I would just like to thank all my colleagues who worked with us in this project. The team leader is Dr. Suvarna Already, and all of us worked together for this project. Thank you so much.
Thank you very much, Priya. That's fascinating. And really, when I was just thinking, looking at the vaccination rates and thinking how low that is and how important it is to address this information. We don't have time for questions at the moment. If we have time at the end, we'll gather them. And I'm going to introduce the next speaker, and I can see Clarissa is here. So Clarissa, you have done a lot during the pandemic, and we really look forward to listening to some of your work, especially in relation to people with dementia living in the community. Thank you.
Thanks, Adelina. No pressure then. So, well, thank you very much, Adelina, for inviting me. Always lovely to be joining these events. So I'm trying to share my screen now. Yes, that works. And I'm going to put that on.
So apparently if you go to the top display settings.
I know, I struggle because I also see the Zoom thingy at the top.
At the top when it says display settings?
I can't see it because the Zoom bar is on top of it. And oh, hang on. Now I can move the Zoom bar. Technology. Here we go. So.
Looks good, thank you.
So today, as Adelina was referring to, I'm going to give a very brief snapshot of some of our COVID-19 dementia work in the community. We've also done care and research, but I'm going to focus today on the community findings and on a couple of specific ones for this talk. And I'm also then following this on with talking or referring to our ongoing very large systematic review, trying to review the ever-increasing evidence base into how COVID is impacting on dementia and dementia care. So at the beginning of the pandemic, we were lucky enough to receive funding from the University of Liverpool to conduct a national study, mixed method study, collecting qualitative and quantitative data to try and understand how the pandemic and the face-to-face restrictions are impacting on receiving care for people living with dementia in the community. So I have been working a lot with carers as equal team members, as public advisors, and with people with dementia. And they also told me as this was all happening, oh, I'm really worried about accessing my support group, etc. So in this study, we specifically looked at how face-to-face services, social support and social care services, such as social activities in the community, dancing, for example, or peer support groups, paid home carers coming into your home, or befrienders, or respite or daycare centres, how have they been affected? So what we've done in a very large team of academics, clinicians, people living with dementia and unpaid carers and third sector, we've come together remotely, and in April 2020, we conducted 50 baseline interviews with unpaid carers and people living with dementia across the UK. And we followed up a subsample of them around 3 months later, up to 3 months later. Around 20. So we have a total of 70 interviews, and I will also later very briefly refer to our subsequent international comparison with 4 other countries, also including India. But let's focus first on 2 specific angles of the findings that came out as part of those interviews. And I think the first one I want to share with you is looking at inequalities to accessing care and using care. So we know before the pandemic, and generally this is not dementia specific, but people that are from different backgrounds, for example, from a minority ethnic background, or from a lower educational background, or from a lower socioeconomic background, so with less financial means, people can struggle in accessing the right care. Now, again, that's not dementia specific, that's generally health and social care specific, or based on the gender, or based on where you live. Do you live in a very rural area, or do you live in an urban environment? All these factors can influence whether someone receives the right care and enough care. Now, this is amplified in dementia because there's even more barriers to accessing certain types of care. So what we've done is, in those questions, we've also asked people in with the topic guides, how has it been accessing care before the pandemic? How is it being now? Has anything changed? Is there any more barriers to you accessing any care? So some of the things that we found were, so I'm just moving the bar, service suitability. Now, that was present before the pandemic, but also since the pandemic. And you can see here a couple of quotes. One is referring to how it was before the pandemic by a person living with dementia. So this person is, for example, saying, I'm just not a group person. I don't want to go to a group, but that might mean then she may struggle finding the right type of care, especially if there's, there's no booklet to know all the different services that are out there. So it can be really difficult finding this most suitable care. Then the second quote here is referring to how it's been since the pandemic. And for example, that everything's going online. A lot of things were going online very quickly. And the carer here is referring to the fact that not everyone has access to the internet. And also, if we think about people living with dementia, they can struggle because of their cognitive symptoms to really fully comprehend and use digital means, at least in the more advanced stages. That can be a barrier to accessing care as well. So now that we're at some point coming up to 2 years of the pandemic, it's really worrying. We found this at the beginning of the pandemic, but what has it been now? The long-term implications of not accessing services. Another thing which has ever been present before as well, but more exacerbated and made more difficult due to the lack of face-to-face contacts, was navigating that maze of care. So many carers, unpaid carers, are referring to the fact it's just really difficult. It's hard work finding out what's available. Information, services, maybe even financial support to access the services. There doesn't seem to be a guidebook or any clear information out there. And now if we think about or a lot of things have been done remotely now, it's ever more difficult. But also, if the person with dementia does not have a relative or a friend who can support them, again, that's a huge barrier to accessing care. So it's really important to be aware of all these difficulties and hopefully try and find some solutions. There have also been some novel inequalities or barriers to accessing care, but also more basic necessities. So especially in the beginning of the pandemic, in the first few months, we in the UK or England later, we had the vulnerable lists, and people, so that meant for shopping, people would get priority slots. So particularly older adults, people with specific health conditions. For some reason, dementia wasn't classified as that. So there were struggles for people living with dementia in getting priority slots, in trying to be safe and getting their basic necessities and their basic food. Also, as I was referring to as well, the digital, the remote access, that was a novel inequality, because if we think before the pandemic, probably no or very, very little services were provided remotely. Now suddenly everything seems to be online, support groups, also accessing healthcare in some instances. So that created some barriers in accessing not only social support and social care, but also healthcare for some people with dementia, we found in our study. So that was a focus on the inequalities, and I thought it's really important to just focus on that for a change. But also underpinning all of this is the fact that obviously people with dementia do have cognitive deficits, which become more advanced as the dementia progresses. So let's think for a moment and I've been there. I struggled at times understanding the ever-changing restrictions, and I'm starting to struggle now again with the travel restrictions changing all the time. How is that for someone who has cognitive problems, not just dementia, that can be anyone? It's not clear, it's not clearly communicated, and if something changes so quickly, how can that information be retained? So another focus of our analysis looked at how do people with dementia understand the restrictions and how can they adhere to them, and how are carers experiencing this whole situation. So we found that many people living with dementia were struggling to understand. Suddenly, why does everyone have to wear face masks, etc.? Having to socially distance and not going outside anymore, because usually we heard from many carers that their relative would go outside normally, but then obviously was prohibited. And why can't the grandchildren come over anymore? Why can't they see their family anymore, the loved ones? Obviously, not being able to understand, that leads to a lot of emotional distress, which is also then impacting on the carer, if there is a carer available. So many carers were saying they had to repeatedly explain these restrictions to people. And it just added, as I was just saying, this emotional distress, not understanding why they can't go out anymore. Obviously, in England, we were allowed to go out once a day legally at the height of the first wave or second wave of the pandemic. Again, that was difficult to understand, but we also found that quite a few unpaid carers shared with us that when they were going out with their relative with dementia, many of them were struggling to obviously understand, let's keep the social distance. So they would go up to their neighbors or maybe see a friend on the road and try and pat them on the back or give them a hug or just come close and speak to them. So some carers purposefully avoided having their relatives with dementia go outside because they want them to be safe, but also other people to be safe. And also just managing this all the time was stressful for some carers as well, which obviously led to more social isolation in people with dementia. But also the lack of understanding can actually lead to quite a bit of dangerous situations. So as I was just referring to, many people with dementia, if they were going out at first, they would come up close to friends and neighbors. We also had a couple of instances where here, for example, the daughter was saying her mum rang her and said that she had just been to Morrison's, which is a grocery supermarket here, and the mother didn't understand, oh, that doesn't make sense. Why are there these arrows on the floor and in terms of keeping the social distance? That just doesn't make sense. That's just stupid. In effect, the person with dementia, the mother, has placed herself in a dangerous situation there because she didn't understand the rules. She didn't understand what's going on, the pandemic overall. So that leaves the carer who's not living with her in a really tricky situation as well, because she can't obviously 24/7 observe and look after her mother. So again, there were difficult and sometimes slightly dangerous situations as well. So some of the learnings from the pandemic, this is kind of summarizing overall the study, some key findings and learning so far. Remote support is not the same. It has provided a lifeline, having these digital and remote services, but it wasn't the same. And we actually found some people living with dementia were starting to go on antidepressants in the follow-up interviews because they didn't receive sufficient care. As I was referring to, we found exacerbated inequalities in accessing care, which now, considering the long-term situation, I'm really worried about how that's going to plan out. Services should try to provide safe face-to-face support where possible, obviously within restrictive guidance. And also, we found a lot of emotional upset in people. There needs to be better and easier and for free mental health support. And we've also outlined these in a policy briefing, which was published about a year ago now. So just a couple of, just one reference to our international comparison study. We've been approached by Poland, India, Italy, and Australia to compare our UK findings. So our 5 countries in total have collected an awful lot of data, a greater focus on the qualitative component. And just a kind of reference to this, there have been quite a few cultural variations, but overall, the pandemic has affected people living with dementia and unpaid carers to a great extent in all countries. Less so in India and Poland, but in different ways, at least in our study. But much more data need to get.
1 minute, 1 minute, Clarissa.
That's great, thank you. I'll just go 1 minute over the systematic review now. So we have now, you see below here, our many international collaborators on this, and we've got a couple of carers involved as well. We now want to try and understand and synthesize the available evidence on how the pandemic has impacted and is impacting people with dementia and unpaid carers, specifically focusing on health, mental health, cognition, social care usage, but also financial implications. Now it's much bigger than we thought it would be, and we're doing this on our own time. So I think we're doing quite well. We've had in July, just short of 10,000 records to be screened. We have read as a team through 159 full text, and we have over 60 plus inclusions just being finalized. So we are thinking, because it's so much, we may have to split that into 2 reviews, but we're busy sorting this out and just kind of referring. So some things that come out is that there seems to be an increase in cognitive and behavioral symptoms as a result of the pandemic. Accessing care has been highlighted a lot as a obviously negative, and carer burden, quite a bit of literature on that. And that's it from me. Thank you very much.
Thank you very much, Clarissa. And a lot of work you have been packing in since the pandemic started, and an amazing contribution to our understanding of the impact. And thank you very much. I will again see if we have time for questions after I have put some of the links to Clarissa's work on the chat. I know they've also been circulated on Twitter, but Clarissa, if we've missed anything, please don't hold back. And I'm really, really delighted to introduce now my colleague Cheng Shi, with whom I had the pleasure of working with when she was completing her PhD. It seems like ages ago in London. She's now working in the University of Hong Kong in a really fascinating project. And you have been able to also fit in data collection on COVID into your study. So thank you very much, Cheng. If you want to start sharing your screen.
Yeah, thanks, Adelina. I'm sharing my screen now. Right. Is it working well?
Yes, very well. Thank you.
Okay, great. Okay. Yeah. Good morning, good afternoon, and good evening. My name is Cheng Shi. I'm a postdoctoral fellow at the Department of Social Work and Social Administration, the University of Hong Kong. I'm very glad to join this informative workshop and share our research here. On behalf of our research team, I will present some preliminary findings from our TIPCAR project. We'll introduce more about this project later. Today's sharing will focus on the service utilization of formal and informal care during the post-pandemic period. The title of my presentation is, Does informal care compensate formal care as a consequence of COVID-19? A cross-sectional study on service utilization among community rolling Chinese living with dementia in the post-pandemic period. First of all, I will give you some background information on Hong Kong. Hong Kong is aging very fast compared with many other high-income areas, and it's one of the most rapidly aging societies in the world. As the population aged, the number of people living with dementia is expected to triple from 100,000 in 2009 to 330,000 by 2039. Regarding the COVID-19 situation, so far there have been 12,467 confirmed cases reported in Hong Kong. The bar chart here shows the daily number of new confirmed cases since the beginning of COVID-19 outbreak. As you can see that the number of new cases is very low since the later March this year. And the new local case has been reported since October 8th. At the same time, so far, over 71% of residents have received at least one dose of COVID-19 vaccine. Generally speaking, the situation here is quite safe and stable. Okay, so we can say that life in Hong Kong has been pretty much back to normal. But this is a sort of new normal with measures for prevention and control of disease, such as wearing masks in public areas and minimizing gathering for keeping social distancing. But the good news is the healthcare and the social care service have been resumed and back to normal provision level. We have learned from the news and other studies that people living with dementia have been substantially affected by COVID, as well as their informal family carers. Due to a lockdown or the suspension of social service provision, informal carers were exhausted to provide additional care hours during COVID-19 outbreak. While considering the stable situation and the new normal life in Hong Kong, we are currently thinking about whether informal caregiving for dementia can also back to normal, and whether informal care compensates formal care as a consequence of COVID-19. So in this study, we aim to examine the impact of COVID-19 on service use pattern of formal informal care for people living with dementia during the post-pandemic period. This is actually a part of our TIPCARD course of dementia study. TIPCARD is a 3-year research project aiming to provide evidence and tools to inform policy for dementia care in Chinese community. Dr. Gloria Wang is our principal investigator, and we also have a close collaboration with the STRAT team, led by Adeline and Martin. The course of dementia study is one of the interrelated studies of TIPCARD. It aims to generate new evidence on cost and the impact of dementia in the community. When COVID-19 outbroke, we were planning a data collection. Given its impact on service provision, we decided to wait until the situation is stable. And we also realized that the service utilization might be affected by COVID-19 even after the formal service provision get back to normal. So we included questions about COVID-19 impact on service use. We started a phone survey since later March this year. So this is the post-pandemic period. Currently, we have recruited about 500 diet participants, people living with dementia and their informats, usually the family carers. And our data collection is still ongoing. Today's sharing is based on our current progress. We investigated in the informal care time of multiple informal carers spent on taking care of people living with dementia in the past 30 days. The resources utilization in dementia, the RUD instrument, was used for capturing the care time for ADL task, IADL task, and the supervision time. COVID-19 impact on service utilization was asked as due to COVID-19, to what extent your recent service utilization in healthcare, social care, informal care has been affected. Participants can report no impact, increase the service use and its change percentage, or decrease the service use and its change percentage. Our dependent variable is the increased informal care hours due to COVID-19. It's generated by self-reported change percentage and the current informal care hours. Since a few participants reported no impact, they are a mass of 0 in the dependent variable. The independent variables are whether current service use in informal care decreased due to COVID-19. They generated for care. And the covariates include social demographics, number of informal carers, diagnosis of dementia, comorbidity, functional status, and cognition. Given the features of dependent variable, a two-part model was used to examine the association between increased informal care hours and a decrease in formal care service use. So firstly, a logical regression was used to predict the probability of whether informal care increased, and then conditional on a positive value in dependent variable. The generalized linear model was used to predict the level of increased care hours. This table shows the sample characteristics. Mean age of people living with dementia are 82.7 years old. The majorities are female and have received a diagnosis of dementia or mild cognitive impairment. The higher ADL and IADL scores present better functional status. High MoCA scores present better cognitive level. Most of our participants are service users of healthcare, particularly the user of outpatient service. Half of the participants received home care or daycare service in the past 30 days. This is because we purposefully recruited some participants who are not the service user of social care. Regarding the use of informal care, we found that over half of the people living with dementia have more than one informal carer, and over 1/3 participants reported they have more than one main informal carer. For average, the monthly informal care hours of multiple informal carer are about 500 and more hours. So about 45% of informal care time is attributed to supervision. That means a person living with dementia in Hong Kong received 4.5 care hours for ADL task, 5.8 hours for IADL task, and 8.3 hours for supervision per day from multiple informal carers. As you can see that they heavily depend on the informal care. Regarding the COVID-19 impact on service use, although most participants reported no impact, among those who were affected, more participants reported a decrease in service use in healthcare and social care, while an increase in informal care was more reported. Among those reported a decrease in formal care use, the average change percentage is about 50% for healthcare and 17% for social care. Among those reported an increase in informal care, the average change is about 53%. This table presents the results of two-part model. In the first part, the loaded model showed those who reported a decrease in social care or healthcare had a higher likelihood of receiving additional informal care. In the second part, the GLM analysis showed those with more informal care or with more IEDL needs received higher level of increased informal care hours. Based on current data and analysis, we currently observed changes of service use pattern in formal and informal care due to COVID-19, and the changes of formal care is related to that of informal care. We may infer that informal care may be invoked as a compensatory mechanism for the reduced informal care. However, the increased informal care hours is more dependent on the availability of family carers and care needs. So even in the post-pandemic period, the service provision, the formal care service provision gets back to normal level. The service use pattern in informal and formal care can be changed as a consequence of COVID-19. The long-term care policy should pay more attention on the impact of COVID-19 on formal-informal care relationship, particularly for those reduced the formal service use as well as their informal carers. This is my presentation. Thank you for your attention. Please feel free to contact me for more details.
Thank you very much, Cheng. And we'll now go back to England, and then we will hopefully have a few minutes for questions. And I see there's already some in the chat, which is fantastic. So now I'm going to actually introduce my neighbor, who is Stacey, and I both live in Canterbury, although we work in different universities. And I'm really delighted that she will be presenting on her work as well, also looking, I understand, at both people with dementia and carers, the impact. So all yours, Stacey, and we can see the slides very well.
Great, thank you. So as Adelina was saying, I'm presenting today on a cross-sectional study in England of people living with dementia and their carers, and this study was conducted by myself and colleagues at the University of Kent. It's been funded by the National Institute of Health Research under the RFPB programme, so the usual disclaimer is required before we begin. So just a little bit of background context. What we know is that there are over 767,000 people living with dementia in England and Wales. There are slightly different estimates. This one is perhaps a little bit out of date. That could be larger at this point in time. But the other thing that we know is that 2/3 of them live at home in their own homes. And for this group of people in particular, and also their family and friend carers, community-based social care is really vital. These services that fall under a whole range of different approaches, including home care, day centres, activities, and other types of support, are really important in helping people to maintain their independence and also address quality of life related needs. And that's not just for the person living with dementia, but also their family and friends as well, which I think links quite nicely with the other presentations that we've had in this session. So it has that kind of dual focus. However, one of the things that we know, for example, in England, but I think also in other countries, is that this group is at risk of being overlooked in research. And in the English context, a good example of this is that we have national social care data collections, one of which is the Adult Social Care Survey, which happens every year. It's a national survey of people who use social care, both community-based and residential. But for that community-based population, the current guidelines actually exclude people who are unlikely to be able to self-report from the sample. And that will include substantial proportion of these people living with dementia, particularly those living in their own homes. So with that background context, one of the ideas behind the study, this study that I'm presenting on, was to look at methods of how you actually collect outcomes data, social care information from this population. And there were three aims, and the first two related to that question: how do we collect that data? This study was designed and put together before we'd even heard of COVID. So what we were trying to do was instead look at this general problem and using two different approaches. First of all, proxy reports, which is where we would ask a carer to report on quality of life outcomes, but also a method that's approach is looking at quality of life outcomes for carers and being able to look at both of those perspectives. And this is drawing on work that we've been doing at the University of Kent for the last few years, using a questionnaire called the Adult Social Care Outcomes Toolkit, or ASCOT. The third aim, again put together before COVID, was wanting to understand the factors related to social care outcomes. And again, this is part of a larger body of work that we've been doing. What we're wanting to understand is how social care impacts quality of life, but also other factors that might put people at risk of low quality of life outcomes. So those inequality questions, which Clarissa drew our attention to in her presentation. And again, this study, as we approached it before COVID arrived, what we set out to do was to survey carers of people living with dementia in England, people living in their own home and using community-based services. It was designed as an online and postal questionnaire, and we wanted to collect a variety of different things, including individual characteristics, information around the situation of caregiving, things like the number of hours per week, whether the carer and care recipient live together, looking at the type and the intensity as well as satisfaction with care services used. And we collected a range of outcome measures, including the ASCOT carer, self-reported, and the ASCOT proxy reported, but also the EQ5D and the DEMQOL, which is an outcome measure designed for people with dementia and their carers. And this is just to give you a flavour of what I'm talking about when I refer to the ASCOT. The ASCOT's an 8-question questionnaire, and it covers aspects of quality of life that can be affected by social care support. And that includes things like personal comfort and cleanliness, food and drink, but also things like maintaining social relationships, having independence and being in control, being able to do things that you value and enjoy, and also feel that you're being treated with respect and dignity. And just to give you an idea of what the questionnaire looks like, so this is one of the questions from the proxy report version. What we did was we took the questionnaire and we developed it with potential proxy respondents, so that's carers as well as care workers, although we've gone back and decided to focus actually on family members and friends, carers. And we adapted the questions, and the feedback that we got from people as we developed it is that we couldn't just ask the question and allow the people just to give one response. There was a very strong feeling that we needed to collect two pieces of information. So you can see there are two columns. On the left, we ask the carer to say what they think about the person they support. So what's their view? And on the right-hand side, they're asked to rate what they think the person they're representing would say. Now, this question relates to food and drink, and to give an example, we might be talking to a carer and they might be supporting their spouse, and they might say that their spouse eats really badly, just eats junk food, and that they don't think that's very good. So they'd rate that in one way. But and again, this came up quite often. They would say that actually their spouse was really happy with what they ate. And so they'd say the top response, so you'd have a slight difference in the ratings. And by having this format, it allowed people to express those differences. And this is just to give you an idea of the Ascot carer. This version of the questionnaire includes 7 questions. Some are the same as the Ascot proxy. So things like social relationships, control over daily life and safety. Those at the bottom are specific to carers, and in talking to them, these are aspects of quality of life that they identified as important. So things like feeling supported and encouraged, self-care, so being able to get enough sleep, eat well, getting to medical appointments, which we know can be really difficult for carers, and having time and space to themselves. Now, I've talked about the study and set it up, and that was fine, and we started to go ahead. We actually began the study, the data collection, in January 2020, and we finished data collection in April 2021. And what happened during that time is illustrated in this diagram. We actually went through a lot of change as there were different phases of restriction applied in England. So we had everything from the pre-pandemic phase to the first national lockdown in England, which went from March to July. Then we went through a period of minimal restrictions. Then we had a regional tier system, then another national lockdown, then back to the tier system again, third national lockdown, and then easing restrictions. So there was a lot going on in that period of data collection. So actually, in staying on that slide, I think that what we realised is that we had the data and we would go ahead and do what we intended to do, those 3 aims of the study, but we couldn't just ignore the fact that we had this rich data collection that was happening during the pandemic. So we actually had 313 carers complete the survey, which was slightly higher than the 300 we were aiming for. And to give a little bit of an idea of the sample, the average age of the carers was 62 years, 3/4 were female, just under 95% were white or white British, and around half were providing more than 50 hours of care per week. And they were mainly caring for either parents or spouses or partners. Just under 60% lived in the same household. So the first thing that we wanted to get an idea about was the question that I showed you. There are 4 response options, and those bottom 2 relate to having social care related quality of life needs. So what we did was we combined those bottom 2 responses and wanted to get an idea for each of the questions, what proportion of the sample had unmet social care needs. We've got to remember that one of the inclusion criteria is these are all people who were in contact with services. Around 2/3 were using home care, the remainder were using some kind of day activities, and then a tiny proportion were perhaps either using just equipment or some kind of volunteering support. So these are all people who are using some form of support. Now, I had expected this, but I was actually quite surprised that with carers in 5 of the 7 areas of quality of life, over half of the sample were reporting unmet social care needs. You can see safety was only 3%, that's good, but self-care, we're even looking at around 1/3 of the sample, the others over 50%. The pattern for the proxy reported quality of life for people with dementia is a little bit different. So over 50% were reporting needs for the person with dementia in what we call the higher order domains, so things like control over daily life, social relationships, and occupation, which is around doing meaningful activity. In the other domains, it's lower, but I was also drawn to the either 21% or 35% of people saying that they had needs with relation to dignity. So they were reporting that the care that they were receiving was not being conducted in a way that was enabling them to feel respected and to have their dignity recognised as humans. And I was, again, that for me struck me as quite high. So what we then did, going back to aim number 3 of the study, is we wanted to understand what are the factors related to quality of life outcomes. And so we included the variables that we expected to see relationships, but we also included, you can see towards the bottom, the survey completion phase by looking at these different stages of the COVID-19 restrictions. And first of all, looking at carer quality of life, it was perhaps as we'd expect. So we know from previous studies, things like poor health are related to poorer social care related quality of life outcomes. Things like providing over 50 hours of care per week are related to worse social care related quality of life outcomes. And also things like being co-resident with the person being supported, having financial difficulties. But also what seems to be positively related to outcomes is being satisfied with services. So this is the carer being satisfied with the social care support. And it's interesting here that actually with the carer's quality of life, looking at those stages of COVID-19 restrictions, they were not significant. So we reran that with the proxy responses. And you remember we have the 2 columns. So we looked at those separately. The left-hand column is what we call proxy. So that's where the carer is saying what they think. And what we found was that there were various things associated with better quality of life outcomes that related to the amount of care, both paid and unpaid. So whereas the 50 hours or more a week was negatively associated with carer's quality of life, it was positively associated for the person with dementia. But also looking at hours of home care, use of day activities. And also interesting, this comes up often in our research, is the design of the home. So having a home environment that's conducive for care is really important for quality of life outcomes. Negative associations were seen though for having more severe cognitive impairments, and also there was an interesting blip. So there was a bit where we had the first lockdown, easing of restrictions, and then they were reintroduced. And that seemed to be associated with negative outcomes in this model. Then we looked at the proxy person rating. So this is the carer imagining what the person with dementia would say. And this was different. We didn't see the associations with paid and unpaid care intensity that we saw in the first model. But what we did see was associations with activities of daily living with difficulty and cognitive impairment, and also almost a cumulative effect. So those later stages of the pandemic, you could see that there was the negative association was significant. So there seemed to be something going on there, which is interesting. So what can we conclude from this? Well, I think the headlines for me are the high percentage of unmet social care related need, especially among carers. This is a relatively small sample, and what we were trying to do is to test out the method, and I think we need to hold that in mind. But even so, there does seem to be a high level of unmet need. And our hope will be that this will then be included in the national data collections, and that will give us a more accurate picture of what's going on, and also allow us to compare dementia carers with other types of carers. Also, again, understanding and identifying carers at risk, so those who have their own health problems, caring for more than 50 hours a week and experiencing financial difficulties. But what seems to be positively associated is satisfaction with services. And this comes back to a policy aim in England. Whether it's being achieved is another question, but the policy aim of making sure that carers' perspectives are taken into account in assessing need and in putting care in place. So we call this things like the whole family approach to assessments, or urging professionals to think carer. That seems to bear out in this data, that if the carers considered and that they're able to then be satisfied with the care, that means that they have better outcomes. And also some of these interesting interactions that we see with COVID-19 restrictions, I'm not quite sure we can say there's no association for carers' quality of life, so everything's fine. I think that the starting point of very high unmet need is a concern. And listening to some of the qualitative evidence, it's almost like the pandemic hasn't really impacted them, but things weren't good to start with. But those negative associations for the quality of life of people living with dementia do suggest some kind of increase in need. And I think that this is an important area to keep an eye on and to focus on, particularly projecting into the future and keeping an eye in population shifts and unmet need in the wider population. So that comes to the end of my presentation, and just to have my details and more information about the ASCOT tools at the web link there. Thank you very much.
Thank you very much, Stacey. And we do have a little bit of time for discussion, and we also have a first question with which to start. And I'd like to invite Ange to maybe make your question. And I know there's it's been a little bit answered by Stacey, but maybe we can also hear the other voices. Ange?
Yeah, thank you very much, Adelina, and thank you to all the speakers for excellent presentations. My question was really about data. So you've all done really fantastic work on understanding the lived experiences of people with dementia and their informal caregivers in the community. Apart from obviously Stacey's work, where there's maybe more of a quantitative aspect, a lot of that comes from interviews and qualitative reflections on experience, which is hugely important and valuable. And I was wondering whether if we want to ask our governments and care systems to make substantial improvements to improve the lives of people with dementia and their caregivers, there will always be an ask for data and figures. And I wondered whether you can make a comment on whether those figures are adequately being collected at governmental or care system level. And also, I guess a secondary question is what we can do as patient associations and civil society organizations to really advocate for better data collection on care and care in the community for the benefit of people with dementia. So apologies for a long question, but it's such an interesting topic and I'd love to hear your thoughts.
I know I answered in the chat, but just a very brief comment. I think the study that I presented was really driven by an awareness of the lack of data for this group of people. And at the moment, we've now got the tools and the approaches. We've still got the next step to try and persuade at the government level, the national level, that we should be collecting this. But it's reassuring that the voices, the response we've had, there's a recognition that we do need this type of data. And if we don't have it, then we can't build a case and understand what's really going on. I think the key thing with the data collection that I mentioned is it focuses on people already receiving care. We don't then have a view of people who have yet to access care.
And that would be formal care, sorry to add that. Just to, yes. I think the next hand was from Clarissa.
Yeah, I think there's the other issue though as well, that the social care and social support sector is just so fragmented, but also at least in this country, not my country, but this country, UK, that people often just get the diagnosis if they get it, but then they're left without any further follow-up, without any single point of contact. There's no kind of coherency afterwards. So if that's not addressed either, then I think it'd be really difficult to collect this coherent data, and also thinking about all the services that are out there. I work with organizations that receive funding from different sources, different angles. So again, there's no clear oversight. So it's the system approaches that need to change a little bit too. But yes, we do need much better data, as the pandemic has shown.
Thanks. And Priya, from an Indian perspective.
Yes, I will. I would like to just add on to what Clarissa said, because the system, the larger, the more I listen, the systems and the difficulties seem to be very similar, though the context seem to be so different in terms of cultural and diversity and things like that. In terms of how the data can actually inform the care systems. A number of projects that we are working on, even the STRIDE project has this mandate of informing policy, informing public health professionals to see how much systemic changes can be built into what is currently ongoing as care support, so that the people with dementia and the carers can have a better access, better reachability. We need, as Clarissa mentioned, a lot of fragmentation exists, and people do not know where to reach out once a diagnosis is made. So we still need to inform the existing systems with whatever data that we can, and we are making attempts to do that. Hopefully, over a period of time, there will be better changes. We look forward to that from all these. Thank you.
Thank you, Priya. And Chen from Hong Kong.
Yeah, it's just a quick point I want to add is, actually the reason why we conducted TIPCA project is because we found there are some data gaps. So before we started the data collection, we conducted a data map in the beginning to see where the gap is for the data. And in our data collection, as you may notice that we started the data collection starting from the March in this year, but currently we only finished the half of them. The reason is we would like to recruit some people without diagnosis. So it's quite challenging to recruit them. And as other colleagues mentioned, usually the government only have the records or the information for the service user of formal care or the healthcare. So we would like to know the service utilization among those who are not service user of the formal care and those who are not receiving a dementia diagnosis. So this is kind of the reason why we conduct this. Yeah, thank you for the question.
Thank you. And do we have any other questions? You can also the speakers, you can ask questions of each other, because I do think there are some very interesting parallels and relationships between the different studies you have presented. Chang, your hand is up. I don't know if you wanted to come back or if it's historical. And I was wondering, Clarissa and Stacey, I'm going to put you on the spot as you're both working in the same country. How do you see the relationship between the findings between your two studies? I don't know whether maybe Clarissa, if you want to react first and see.
I must say I've been doing some work in the meantime, listening in the background, sorry.
No, that's all right. So I was just wondering about the relationship in terms of the patterns of access to care that you have explored. So apologies for putting you on the spot. I'm going to quickly move on and completely understand as it's a very busy time of the year. So I was thinking about these different phases of the pandemic, and I was struck, Stacey, that you didn't find an impact from the perspective of the carers, but you found that it was on the perspective of the people who are using care. But this is a proxy kind of measure, and I was wondering how much of that would be a sense of passing on the distress and not quite admitting it for yourself when you are answering as a carer, which is an issue sometimes with proxy, but of course this is the only way we have quite often.
So I've been reflecting a lot about this, and my impression, and looking at the data and doing some comparisons from other similar data collections, my impression is that what's going on with the lack of impact for carers is that they're starting from such a low point. that it's just not having that impact on quality of life. And that for me was listening to Clarissa's work and sort of other things, I think is borne out in some of this qualitative evidence. So if you're caring for more than 50 hours a week and you're pretty much in the house anyway, going through a lockdown isn't going to make as big an impact as if, you know, you're living in a different situation. I think the proxy responses, I didn't have time to explain, but just to perhaps explore briefly, I find it interesting that those two different perspectives, you have slightly different things going on. And of the two, the proxy ratings, I think are the ones that are giving us the best view of what the carer thinks that support is doing. And that actually what you're generally seeing is that support was stepping in and continuing to have some impact, but there did seem to be that blip in the middle. And I do wonder whether that's partly to do with some of the transitions that were going on during that time. But again, it's rather difficult, because if we'd have wound back and known that COVID was going to happen, this survey would have had a qualitative element, and we could have begun to answer some of the questions as to what was going on. But back to your original question, that for me, I think it raises lots of interesting questions and observations, looking at the qualitative evidence that's been presented and bringing it together.
Thank you. And I'd like to end this session by thanking all of you, not just for the presentations today, but for the rapid way in which you have mobilized or adapted your research to help us all understand so much better what's going on. It really does make a difference, and it's incredible to see. I was thinking of the study of from India and from Clarissa's work, how quickly you stepped in to start capturing this data, and also thinking of the TIP card project and this ASCOT project, how you adapted to be able to help us gain an additional understanding while also keeping on collecting the data that you needed. And I think this is a really valuable effort, and hopefully will help us be better prepared for the future and all that. So thank you all. We're now going to have a break, so I do encourage everybody to sit and to get up, sorry, and move and have a coffee, everything you'd like. The next paper we'll have is from the Netherlands, is on COVID-19 and people living with intellectual disabilities, another group like people with dementia who have often been forgotten in the pandemic. So I hope to see you all soon, and enjoy the break, and thanks again. Bye.